of employers
Sorry.
who live with obesity, just 65% of them recognize it as a chronic disease to be treated. I'm sure if the question was asked for diabetes or hypertension, the percentage would certainly be about 100. Everybody would agree. So with that gap in perception, it has led us to this point where the focus for the past decade or so has been on weight loss, which is kind of short term, with the focus being BMI measurements. Obesity, as we know, has many etiologies and comorbidities associated with it. More than 300 comorbidities are known to be associated with obesity. So because of the way we've been managing it, it has resulted in a 12% increase in the obesity prevalence in the United States. So between the year 2000 and 2018, we have seen a 12% increase. So 42% of adults in the United States currently live with obesity. And there's a projection that by 2030, just 9 years away, is going to be a 51%. So it's something we really need to take action on, not only because of the costs, the annual costs in the trillions to manage obesity, but just because of the way it affects different ethnic groups. And we can see on that, the bottom slide, the social determinants of health. As a result of that, there is disproportionate prevalence of obesity based on ethnic groups, with the Blacks and Latinx having an obesity prevalence of 1 in every 2. So what options do we have and what have we been using? Treating obesity as an acute condition, not the chronic condition which it is, has resulted in the weight cycle. So if we see a patient, we focus on the weight loss, they lose the weight, then as a result of weight loss, we've come to understand that there is an increase in hunger, there is increase in desire to eat. When people lose weight, there is also a decrease in our satiety hormones. We're talking about GLP-1s, our incretin, our insulin, all those hormones decrease in patients who have lost weight. And then on the other hand, our hunger hormones tend to increase. Metabolism slows down with weight loss, and then we go back to that same cycle. So unless we change approach, the treatment paradigm, patients are going to keep getting through this fatigue, and I'm sure the prevalence is going to keep continuing. So today, the focus is going to be mostly on the pharmacological options that are available for obesity treatment. And this is a diagram showing us what is currently approved for long-term weight loss. So starting on the left for me, Olistart can give us up to between a 6 to 8% weight loss. Bupropion naltrexone can give us up to 8%. We can use phentermine, topiramate. With that, we have seen in clinical trials that there is up to a 10% weight loss. And the last group, which is going to be our focus for tonight, is the GLP-1 receptor agonist, for which we have 2 approved molecules for weight management. Of note, there are other GLP-1 which are for other companies, but the focus today is for these 2 products that are approved for weight loss and which are products from Novo Nordisk, semaglutide and liraglutide. So these are some of the parts of the body, the organs of the body where GLP-1s can have an effect. For weight management, chronic weight management, we'll look at the effect on the brain as well as the effect on the pancreas and in part the intestines. So we're going to see this slide again come up towards the end of the presentation. So liraglutide was approved under the brand name of Saxenda for the management of weight loss, or for chronic weight management. This is a snapshot of the clinical trials that were conducted to support the approval of liraglutide for weight management. So we have trials in different disease populations. We have it in patients who have pre-diabetes. We conducted trials on patients with sleep apnea. And also we see this other one on the bottom right, showing liraglutide in the patients with type 2 diabetes. So this was an important population to study because we know how much this population struggle with losing or managing their weight. So for this trial, they were all designed to be randomized controlled placebo-controlled trials. And I would just want to point our attention to the one on the bottom left, depending on how you're seeing it, with the 3 arms. So we're looking at the liraglutide 3.0, which is Saxenda, and then liraglutide 1.8 is actually Victoza, which is the one that is approved for glycemic control, and those are the arms. What did we see in these trials? Oh, sorry. This is the dosing schedule for liraglutide that was used in the studies, as well as used in FDA-approved dose escalation. So we start with a dose of 0.6 dosed once weekly, and then once daily, sorry. So it's given once daily, and after 1 week, we can now increase the dose to 1.2, and following that order, and by week 5 onwards, we expect the patients to be on the maintenance dose of 3. If a patient cannot tolerate a certain dose, then it can be extended on that one dose for up to a week, and then try to escalate. For patients who are not able to lose a certain amount, 4% of their weight within 16, I think that's something that's in the label. If you cannot lose a certain amount of weight, 4% within 16 weeks, then the patient may not qualify to continue. Another thing I want to note here is that Saxenda is also being studied in pediatric population and is approved for 12 years and above. So these are some of the key results that we had, the primary outcomes for the scale trials, looking at those different populations we mentioned. Our focus is going to be on the blue side, not this green, because that was the phase 3A trials. The thick blue lines show us the results for the liraglutide treated population, and then the gray bars show for the placebo. And as we can see, patients who were treated with liraglutide had a statistically significant weight loss compared to patients treated with placebo. And we can have between a 6 to 8% weight loss, as I mentioned earlier, with liraglutide. At this moment, I want to pause a little bit, and I know there are clinicians in the room. There are clinicians in the room, and I would like to get any inputs about whether they see weight loss of this magnitude in the patients, or what they have been seeing in clinical practice.
I'm just curious, when you mentioned on the slide that said that they couldn't tolerate the 3 milligrams and it was titrated differently, what are the side effects? What are some of the side effects if you couldn't go up to 3? Okay, great. So this is the table that shows the common side effects that were seen in the trials. They're mostly gastrointestinal, so nausea, diarrhea, constipation, and vomiting were the most commonly seen adverse effects. So the goal is to slowly titrate them. That's why we have that schedule, so they can tolerate, they can build tolerance as they proceed through the trial or the drug. Okay, so these are the results. I showed results on the effects on weight loss. This one is showing the effect on glycemic control. And as we can see, the slide, the left side of the slide, we can see that the thick blue line representing Saxenda and the light blue, which represents Victoza, had statistically significantly reduced weight compared to the A1C in the placebo arm. The chart on the right says the same thing, but it's telling us what proportion of the patients achieved a less than 7% A1C, so which is the ADA target. And we can see that over 69% of the participants taking Saxenda achieved that. So I just mentioned these were the most common adverse events. And with that, we're transitioning to the second molecule that was approved last summer. It's approved under the brand name of Wegovy. It's semaglutide 2.5 milligram administered subcutaneously. This is a snapshot of the phase 3 trials that were done to support the approval. And so we call them the STEP trials. Step 1 was the biggest of all of the 4 trials I'm going to briefly summarize here. And all of them were 68 weeks long. So we had a 16-week dose escalation and then a 1-year on treatment. So the dose escalation was from week 1. So it's once a week, but after 1 month, you can escalate to the next dose. In the next slide, we're going to see the dose escalation in detail. I would like to point us to the step 2, which was also the trial that investigated the effect of semaglutide in the diabetes population. So we can also see here that there are three arms. The light blue arm, which is semaglutide 1.0, is currently approved for glycemic, for the management of glycemic control in patients with diabetes. So we have that under the brand name of Ozempic, and then the 2.4 is the Wegovy. So it's a higher dose of the same molecule. And then we have the placebo arm. In step 3, the goal of the research was to see what is the effect if we intensify behavioral therapy. So it's the intensive behavioral therapy trial, and the patients were initially started on very low calorie diet and then proceeded to receiving the intensive behavioral therapy, which is more sessions of counseling. Step 4 is an interesting trial where they were trying to see what would happen if a patient starts using semaglutide, Wegovy, and stops it at some point. So all patients in the step 4 trial were initiated on semaglutide following the dose titration, and only the patients who were on this maintenance dose by week 20 were then further randomized, such that they can see what would happen if a patient starts taking the medication and stops. So that was the important thing about this. As I mentioned earlier, they were all 6 to 8 weeks long.
Question. So how aggressively are patients treated with Zofran and antiemetics in these trials?
Another question for those who are listening from home. The question was,
In ramping up the dose of these agents, both for liraglutide and Saxenda, how readily was Zofran or antiemetics prescribed to get them to target?
Yeah, the question that I just got was how readily were patients treated with antiemetics as they went through these trials. I would say I have not really found it. I didn't have that question in mind. So it is something that I can look in the data and provide you what proportion of patients were getting antiemetics. So I can get back to you with that. So I'm going to proceed. Is it mine?
No.
Thank you. So we're trying to use the mic, but it didn't work well. So we're going to proceed with the dose escalation for semaglutide. So we saw the dose escalation for liraglutide, which we escalate every week. But since this has a longer half-life and it's dosed once weekly, the dose escalation happens every month, every 4 weeks. So they start with the 0.25, then they go to the 0.5, and by week 17, the patient should be getting to the maintenance dose of 2.4 milligrams per week. So these are the top results for the primary outcome, which is the percent change in body weight across the 4-step trials that I introduced earlier. And as we can see, the dark blue line is representing semaglutide, and then for step 2, the light blue line is the Ozempic that I mentioned earlier, which is approved for glycemic control. Semaglutide showed a higher weight loss across all the populations that were studied, including patients living with diabetes. So patients could lose between 10 up to 17.5% of their initial body weight. This is another set of outcomes that were evaluated for the step 1, 2, and step 3, but not for the step 4, looking at the proportion of patients that lost at least 5% of their body weight. The FDA, that is the requirement for any weight loss medication for weight maintenance or weight management. So we can see that over 86% of patients in step 1 and step 3 lost at least 5%, and 68% lost at least 5% in the step 2 trial. And the researchers also looked at the effect on glucose metabolism by looking at the changes in A1C. And this is still in the step 2 trial that looked specifically at patients with diabetes. And we can see that there was a statistically significant difference. The graph on the left shows us that the patients who were on semaglutide had a 1.7 reduction in their A1C compared to the 0.3 in the placebo group. On the right, The dark blue line is still for semaglutide 2.4, which I said is Wegovy for weight management. And then the 1.0 is Ozempic. And we can see that both of them had greater reduction in A1C, but the higher dose also came with a higher reduction in A1C. Like I showed earlier with the liraglutide, the common adverse events were mostly GI related. And with the dose titration for all the trials combined, the step 4, the STEP program, there was more than 90% of patients who completed the trial. So although we had these adverse events common, more than 90% of the patients in the STEP trials completed the trial.
Looking at the adverse events, the hypoglycemia is much lower in the Wegovy trials compared to the Saxenda trials. It was like 30% in the Saxenda, or 26% had hypoglycemic events in diabetics, and now it's only 6%. Maybe someone else can explain the difference. I'm not sure.
There was a lot more patients taking sulfonylurea in the liraglutide trials than in the semaglutide trials. And most of the hypoglycemic events are because people were taking insulin sacrifice.
Okay.
So I can't say definitively, but I imagine that's what's driving the difference.
And then I guess maybe a question for the room would be, in practice, do you guys stop sulfonylureas, or, what about, right? Yeah.
We would reduce the
I wouldn't do it without doing something else. Okay. And what about like someone who's, pre-diabetic that's not on any medication? Happening because there's, yeah, should be okay, right?
Yeah.
That's what I think. I just, a lot of it. So I'm asking. Thanks for the free side.
That's the mechanism of action, right?
Yeah.
Because all GLP-1s work in a glucose dependent manner. So I would say stop saying that because apparently people just put it out. But what that means is the drug doesn't work unless your blood sugar's too high. So in theory, right, for the most part, I would counter that I've seen some lows that hormonal. Sure. So yeah, anything can happen. Yeah, exactly. Yeah. All right, go ahead.
Okay.
Thank you.
Yeah. Just to summarize for those listening online, there were conversations about patients having hypoglycemia, and then the difference between the scale trials, which was for the liraglutide, and then the STEP trials. And the response we got from Reese was that the proportion of patients who were using increasing insulin-provoking agents like sulfonylureas in the scale trial was higher, and then patients using insulin was higher there. So that was the reason why they had a higher frequency of hypoglycemia. So I said I would come back to this slide as a good transition to the next part of the presentation, just giving an overview. Most of what I discussed, the activity of GLP-1 in weight management goes through the brain and then pancreas and the intestines. I think Tanya is going to come and talk a little more on how GLP-1s affect other organs of the body. And before I hand it off, this is our scientific exchange website where we have information for different medications. So we have medical information, scientific information, and also conferences. So we just came back from Obesity Week. Most of the data that we shared there will soon be uploaded here. I'm going to leave it with Tanya, and then she can share it with you. So it's a quick link to get to the website. Thank you very much.
Thank you all so much for being here tonight. Again, I'm Dr. Tanya Vincent. I'm the president